thanks for joining us for Challenges of the Diagnosis and Equity of Long COVID Care. I am Vivian Levy, Chief of Infectious Diseases at San Mateo Medical Center, the safety net hospital and clinic system for San Mateo County, and faculty at Stanford's Infectious Diseases and Geographic Medicine Division. Since the onset of the COVID pandemic, millions of persons across the globe have experienced ongoing symptoms after infection with SARS-CoV-2. The long-term health effects of COVID, known as long COVID, are profound. Despite long COVID's relatively recent emergence, numerous definitions and descriptions of long COVID have already been published. However, no common definition for long COVID had yet been agreed upon. There existed a high heterogeneity in existing definitions, which limited the opportunities to compare interventions and gather evidence of long COVID. The lack of generally accepted and consistent definitions for long COVID presented challenges for clinical management, treatment, research, surveillance, and support services. With this in mind, the National Academies of Science, Engineering, and Medicine, known as NASEM, created a working definition of long COVID, with the most recent iteration of this working definition released June 2024. When creating a definition for a new disease entity, it is important to realize that no published standardized guidelines for the development of disease definitions exist. The NASEM committee articulated several possible elements of the long COVID disease definition. These include attribution, the source responsible for causing the disease, time, onset of disease, clinical features, including symptom course, duration, and symptom severity, equity implications, functional impairment, the effect of the disease on daily activities, alternative diagnosis considerations, biomarkers and lab criteria, including imaging and cognitive assessments, and risk factors, characteristics associated with a higher probability of disease or adverse outcomes. The NASEM long COVID definition will evolve as new evidence emerges. The NASEM long COVID definition includes the following terms, which are also defined. Long COVID, a patient-developed term used for its simplicity and familiarity that can facilitate communication within and between the scientific community and public. Infection-associated chronic condition, a term which applies to a variety of chronic conditions that can be triggered by viruses, bacteria, fungi, or parasites. Use of the infection-associated chronic condition term highlights the ongoing nature of long COVID and its association with a triggering infection without conveying any unwarranted conclusions about pathobiological mechanisms. The disease state term emphasizes the systemic realities of long COVID. Historically, there are numerous examples of infection-associated chronic conditions occurring after pandemics. Polio epidemics in the 20th century were at times followed 30 to 40 years later with new or progressive muscle weakness and functional deterioration in polio survivors. The 1917 to 1920 influenza pandemic led to a chronic encephalitis known as encephalitis lethargica, which persisted up to the 1930s. Significant numbers of these patients developed post-encephalitis Parkinsonism. More recently, Ebola virus, with the first case identified in 1976, led to chronic symptoms of arthralgias, ocular symptoms including uveitis, and auditory symptoms. The 2002 to 2004 SARS outbreak and the Middle Eastern Respiratory Syndrome, first identified in 2012, can lead to chronic fatigue and psychiatric illness. 2024 National Academy of Sciences long COVID definition is an infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous, relapsing and remitting, or progressive disease state that affects one or more organ systems. This figure highlights key elements of the 2024 NASEM definition. Acute SARS-CoV-2 infection may be recognized or unrecognized. SARS-CoV-2 infection can be asymptomatic, mild, or severe. Long COVID can be continuous from acute infection or delayed in onset. Long COVID is diagnosable when symptoms or conditions are intermittently or continuously present for at least 3 months. Common symptoms listed here can be mild to severe and include post-exertional malaise, persistent fatigue, difficulty concentrating, memory changes, recurring headaches, lightheadedness, fast heart rate, sleep disturbance, dyspnea, cough, taste or smell abnormalities, or gastrointestinal symptoms of bloating, constipation, or diarrhea. Diagnosable conditions listed in the boxed figure may be new or worsening pre-existing conditions. Some important features in the NASEM definition include that long COVID can affect children or adults regardless of health, disability, socioeconomic status, age, gender, sexual orientation, race, ethnicity, or geographic location. Long COVID can resolve over a period of months, or it can persist for months or years. It can be diagnosed on clinical grounds alone. There is no biomarker currently available that conclusively diagnoses long COVID. Long COVID can impair an affected person's ability to work, attend school, and care for themselves. It can have profound emotional and physical impact on patients, families, and caregivers. Certain long COVID symptom clusters listed here should not be missed. These include post-exertional malaise, respiratory symptoms, and cognitive symptoms, which include brain fog, difficulty concentrating, and memory difficulty. As previously mentioned, long COVID can unmask chronic conditions such as GERD, asthma, and sleep issues. As far as attribution of infection, as previously mentioned, the long COVID definition does not require lab confirmation or other proof of initial SARS-CoV-2 infection. The initial infection may or may not have been recognized, in part due to the lack of availability of and limited access to tests early in the pandemic, limited sensitivity of some SARS-CoV-2 tests, and the potential for false negatives, as well as an overall decline in testing rates later in the pandemic. The 2024 NASEM long COVID definition was informed by over 1,300 respondents, which included patients, caregivers, researchers, practitioners, health agencies, health policy and advocacy organizations, payers, and health industry. This qualitative work is summarized in an engagement report on the working definition for long COVID. Engagement participants emphasize the need to address equity in the definition, with one participant saying it could be helpful to include a specific statement around health equity in the long COVID definition. That would maybe be a little unusual to include in a definition, but it is important, if not in the definition, somewhere else. Functional impairment is an important element of the long COVID 2024 working definition. One engagement participant noted, "When I think about long COVID, it's about the symptoms that are causing functional impairment that you do not see." The NASEM definition offers symptom examples, but the list of symptoms is not meant to be exhaustive or to dismiss the significance of other symptoms or conditions not listed. The definition does not list any symptoms or conditions as being required and does not list any symptoms or conditions as being exclusionary. NASEM recommends that federal, state, local, territorial, and tribal health authorities, clinical societies, clinicians, researchers, payers, and patients adopt and use the 2024 long COVID NASEM definition. Federal entities will lead the coordination and collaboration efforts to disseminate and implement the 2024 NASEM long COVID definition. In no more than 3 years, or when triggered by the emergence of new knowledge, federal entities will convene a multidisciplinary group, including persons with lived experience, to update the 2024 NASEM long COVID definition. One hypothesis is that we may see more long COVID in U.S. populations disproportionately affected by COVID, especially by the early variants. In 2020, there was a more pronounced drop in Latino and Black population U.S. life expectancy due to COVID-19. This reversed a decade of gain in life expectancy and reversed the narrowing of the Black-white life expectancy gap that had been seen. In California, as of May 2023, Latinos were overrepresented in COVID-19 cases and deaths. Latinos make up 39% of the California population, but were 44% of COVID cases and 42% of deaths. California excess death rates were greatest for persons born in Mexico or Central America with less than a high school degree, who worked in food and agriculture, or who worked in manufacturing. As of May 2024, 5 to 7% of all U.S. adults are currently experiencing long COVID. Also, as of May 2024, 1 in 5 U.S. adults who self-identify as Latino, seen in red on the attached figure, has ever experienced long COVID. In thinking about possible equity issues that may arise with long COVID care, we should review some general concepts on a suggested approach to long COVID evaluation and management. In general, patients need a symptom-based evaluation for long COVID. Normal test results and ruling out other serious conditions may be therapeutic for some patients. Cognitive testing may be helpful, as may physical rehabilitation, pulmonary rehabilitation, and/or physical therapy. Mental health issues and sleep disturbances should be addressed. One equity challenge in long COVID care is the 26 million uninsured Americans. Some recommended treatments for long COVID listed here may not be covered by Medicaid or in uninsured persons. Other treatments may have limited availability in safety net health systems. Research from other chronic conditions may shed light on possible long COVID equity challenges. Research from other illnesses suggests minoritized patients may be at risk for underdiagnosis and white patients, particularly women, at risk for overdiagnosis. This table comes from a study of approximately 8,000 Northern California Kaiser diabetic patients. Researchers evaluated the association of patient-limited English proficiency, labeled LEP in the table, and physician language concordance, with patient reports of clinical interactions. Reports of suboptimal interactions among patients with limited English proficiency were more common among those with language discordant physicians. Limited English proficiency patients with language discordant physicians were more likely to report physicians not explaining or physicians not always understanding problems in carrying out treatments, as well as perceived discrimination, including patients treated poorly because of language. Other long COVID equity challenges include a need for educational tools for low health literacy populations and long COVID standardized treatment protocols for the safety net. I'll close with some federal resources listed here for disability, which may be helpful for long COVID patients. We look forward to your questions and appreciate you joining us. Thank you.